I'd like to thank everyone for coming today. This is actually the October 8th, 2022 Revolution Cancer International Molecular Tumor Board. My name is Bassem Gwilly. I'm one of your co-hosts today. Actually, my other co-hosts who normally are here, Ramu Subramanian and Silimbaris and Raskamani, couldn't actually make it. So I'm actually going to be flying solo today. Ali Ukar also couldn't make it today. So these are disclosures. As you know, our opinions are ours alone. They do not represent any of the institutions that we're affiliated with. So today we're going to have an exciting conversation. We're going to talk about Merck. We're going to talk about microsatellite instability. We're really going to dissect microsatellite instability in a unique way. I don't think most people do. We're talking about 4 different colon cancer cases, which I think are pretty interesting. And so they're all MSI-High. They're all patients of mine over the years. We're going to talk about kind of different ways of sequencing therapy and how they're relatively unique. We're also going to talk about resistance mechanisms that develop in patients getting immunotherapy who are MSI-High. So I think that will be unique too. And then we'll have concluding remarks. We're going to start with the Merck pipeline. I think everybody knows by now that we like to have a pipeline discussion. We like to talk about the future as much as the present. And so let's talk about Merck. So Merck has a reasonable oncology pipeline. I think for a company of Merck's size, it's a little bit disappointing, truth be told. And I think what's important to know is that Merck was in conversations, pretty deep conversations with Seagen to purchase them per rumors for about $40 billion. And then I think that that was likely going to happen, but then Seagen lost their arbitration dispute with Daiichi Sankyo for the technology regarding Enhertu. So Seagen wasn't going to get a part of Enhertu. So I think that reduced their valuation in Merck's eyes. And then there was some conflict regarding that, and that merger has not happened yet. But I do think it was smart of Merck to go and look at Seagen, which has a robust oncology pipeline, very phenomenal technology. And I think Merck really could use that. You know, Merck has Keytruda, which is their big gun drug. It's really their cash cow. It rakes in about $17 billion a year, but Merck, that drug Keytruda is coming off of patent in about 6 years. And so Merck really needs to figure out a way to reinvigorate their oncology pipeline. So here we go with Merck's pipeline. So you can see they have an ILT3 inhibitor, MK0482. That's unique. You know, some companies have this. We'll see what happens there. They have nemtabrutinib, which is a non-covalent BTK inhibitor like pirtobrutinib. This is going to be challenging for them to find a market here. You know, you've got ibrutinib and acalabrutinib and zanubrutinib. Then pirtobrutinib looks very good. It's also a non-covalent BTK inhibitor as opposed to ibrutinib and acalabrutinib, which are covalent BTK inhibitors. But I think they're going to have a hard time finding a footing there. They have quavonlimab, which is an anti-CTLA-4. Really, it's their equivalent of ipilimumab, BMS's drug. It's going to probably get approved at some point. I imagine they'll find a footing here, and they really do need to have their own CTLA-4 drug. Although a lot of us have aversions to CTLA-4 at higher doses, 3 milligram per kilogram doses, they make us nervous a little bit. 1 milligram per kilogram, like in renal cell, and in lung, not so much of an issue. But I think that there are some concerns there. Zilovertamab is an anti-ROR1 antibody drug conjugate. You see a lot of ROR1 now. A lot of companies have this mechanism of action. It's going to be interesting to see what happens there. I'm excited to see what that particular mechanism does. Keytruda, everyone knows Keytruda in a number of different trials as we speak. They have a LAG-3 inhibitor, so that's very similar to relatlimab, which BMS has in combination with Opdivo in the form of Opdualag in melanoma. So we'll see what happens with this drug. I think a lot of people right now are targeting LAG-3. They also have an ILT4 inhibitor, so very, in the same sort of family as the ILT3 inhibitor we just talked about. They have a CD27 activating antibody, so everyone's looking at that immune checkpoint, right? So a lot of people really trying to basically stimulate the immune system to attack cancer. So we'll see what happens there. They have 2 drugs I really couldn't find. And if anyone's watching this from Merck, please know that your website is very difficult to navigate. So if you can maybe make the website a little bit easier to navigate, that would be great. But there were 2 drugs here. I couldn't find the mechanism of action. They have an anti-LIV1 antibody conjugate. So a lot of people are doing, targeting LIV1. I think that's very interesting. Actually, I like the antibody conjugate here. I like the vedotin, like in brentuximab, which we use in Hodgkin's from Seagen. Also tisotumab, which we use in cervical cancer. That's really a Seagen kind of staple. And so I think that's really nice. They have a HIF-2 alpha inhibitor, just like belzutifan, which is approved in Wilms tumor RTC. So it'll be interesting to see what happens there. They have a pan-AKT inhibitor like ipatasertib and capivasertib. And so we'll see what happens there. They have tucatinib, which they share with Seagen. This is a great drug. It's already approved in breast cancer. It's going to get approved in colon cancer. We'll talk about a little bit later today, but this is a really great drug. They have lynparza, which they share with AstraZeneca. So PARP inhibitor, everybody knows this drug. They have their own anti-TIGIT. So, I think people know that the TIGIT antibody, that Roche antibody, tiragolumab, had some issues in small cell and in non-small cell. We'll see what happens there. I think people are worried about TIGIT as a mechanism of action. They have Lenvima, which they share with Eisai, which is a great drug. People like this drug very much. They have their own oncolytic, non-genetic Coxsackie virus vaccine, and then they've got sub-Q Keytruda. So when it comes to the Merck pipeline, I do think there's some room for improvement, and I do think that they really, really should look at purchasing Seagen. That's what I would think about here. So, it's one of my favorite slides. We talked about this over the last several sort of tumor boards. This is really the immune checkpoint. Just kind of walk up and down this immune checkpoint. You can see people just targeting every single protein on this immune checkpoint. So you can see CD80, CD86, PD1, PD-L1, B7-3, so B7H7 is being targeted, CD137, OX40, CD70. So just up and down this immune checkpoint, people just picking off proteins on this immune checkpoint. So we're going to present 4 patients today. So this is going to get pretty cool. This is our MSI-High colon cancer patients. We have 4 patients here. They're all mine. So you can see that they all are MSI-High. They have varying degrees of TMB, actually all of them really TMB high, except for the one person here that was resulted. And they have different mutations we're going to talk about in a moment. So when we talk about, MSI, everybody knows that microsatellite stability is a measure of DNA instability. You can see that here. Really, it's often essentially associated with deficiencies in DNA mismatch repair enzymes. So MLH1, MSH2, MSH6, and PMS2. So MSI-High cancers, I think people know this now, are often responsive to immunotherapy. We're going to talk a lot about that today. This is based on the concept of neoantigens, right? You get all these frame shifts in the DNA. They create all these neoantigens, which really stimulate the immune system. Here you can see the antigen presenting cell, and you can see what's happening in this particular environment. So MMR deficiency obviously correlates with MSI-High status. So when we look at MSI-High, and I think this is a great slide, I love this slide. When you look at the preponderance of microsatellite instability in patients throughout different tumor types, you can see that there's a really high degree of MSI-High in endometrial cancer. That's why you see all these companies with their PD-1, PD-L1 inhibitors in endometrial cancer. Durvalumab with AstraZeneca really trying to establish a foothold there. Dostarlimab's already approved, and Keytruda's already approved there. So endometrial cancer is kind of a big deal with us. But you can see in colon cancer, people, I think, sometimes forget this, but about 3 to 5% of patients with metastatic colorectal cancer are MSI-High. It tends to be more in the early stage patients, about 3% early stage, 2% late stage. And so I think that's really important to know. So, this is the study looking at Keytruda and MSI-High patients against chemotherapy, clearly a significantly prolonged progression-free survival. So that's why many people will use immune therapy up front for patients who are MSI-High stage 4 colorectal cancer. So this is a good example of a patient who got ipi-nivo, who's MSI-High. You see this very big mass here, shrinking pretty considerably. And then there's this study that was published in the New York Times. I think people saw this actually in New England Journal and then in the New York Times. So everybody kind of freaked out about this study. This is that study at Sloan Kettering looking at 12 patients with stage 2-3 MMR deficient, so essentially MSI-High, but MMR deficient rectal cancer. And they basically gave these patients dostarlimab, and all of those patients had a complete remission and did not require chemo, radiation, or surgery, which we typically do in these patients. So we'll see what happens there. I think this was a little bit sensationalized, but it was a nice response. So when you look at MSI-High stage 4 colorectal cancer patients, you can see that there's really 4 regimens that are approved, right? So there's dostarlimab, nivolumab plus ipilimumab, and pembrolizumab. So if you look at the data just kind of across the board, you're seeing about the same overall response rates, anywhere from 30 to 50%. I think people forget this too. And in fact, when I went back and kind of looked at this, I was a little struck by this because every patient I've really treated who's MSI-High stage 4 colorectal cancer has had a profound response to immune therapy. So I thought this was really interesting. You kind of think about it being 100% response rate. It's really not. It's roughly 30 to 50%. The median PFS is really amazing. So you can see 16.5 months with Keytruda, and you can see that 14.3 months with nivolumab, and you can actually see this duration of response over 6 months is pretty phenomenal. In fact, what's happening now is some people are saying at 2 years with immune therapy in this context, you have a complete remission. Do we really need to keep using immune therapy? Are these people actually cured? So you're seeing people come off immune therapy at 2 years and seeing what happens. We talk about tumor mutation burden for a moment. So we kind of talked about how these patients are MSI-High. Now we've got patients who are TMB high also. And so you look at TMB across the board, and the preponderance of TMB high patients in various cancers, you can see in colon cancer, it's kind of middle of the road. Melanoma has a very high tumor mutation burden on average, and that's oftentimes why people think it responds so well to immune therapy. So that's really great. So when we talk about kind of the correlation of tumor mutation burden with response rate to immune therapy, you can see the higher the tumor mutation burden, generally the higher the response to immune therapy. Here, stage 4 colorectal cancer has a pretty good response to immune therapy, and you can see it has a very high TMB in general. So let's talk about patient number 1. So here's patient number 1, 61-year-old female, left side of stage 4 colon cancer, who progressed on FOLFOX, was stable after receiving 4 cycles of FOLFIRI. I met her for the first time at that point. We did, basic NGS, and we found that she was MSI-High, PD-L1 negative, TMB high. Here's her genetic profile. This is a very interesting genetic profile. I think it's very unique. You can see that this patient is an NTRK1 fusion, which is pretty awesome. We're going to talk a little bit about this. I don't get a chance to talk about NTRK fusions a lot, so it's very nice to be able to talk about that today. You can see a series of mutations here, which we'll talk in a moment. She had diffuse peritoneal disease, her CA, and on it when we met her was 101. So people know this article, I think, that I wrote called Playing Chess Against Cancer. It's in biofeminist.com, really how we kind of sequence therapies. So I actually have a talk I'm giving for patients a little bit later. There's kind of 8 essential questions we go through, not important. So this is a very nice slide, I think, that looks at treatment options for stage 4 colorectal cancer, kind of just across the board. I tend to think about them in terms of classes, right? So HER2-mediated therapy, so you can see that lynparza, trastuzumab already available. Be aware that tucatinib plus trastuzumab is already being reviewed by the FDA right now. That data was amazing. This will absolutely get approved. It really had a much better response rate than lynparza, so I think this will absolutely be approved for HER2-positive stage 4 colorectal cancer patients who overexpress HER2. Then, the BRAF regimen, everybody knows this, and so you can kind of walk through this, but this is kind of how I think about the available treatments. So we talk about patient number 1. So with patient number 1, we think about conventional options. We kind of break it down to conventional, surgical, molecular-based options, local regional options, and trials. So this patient, from a conventional option, you clearly have a chemotherapy backbone. So FOLFOX, Xelox, FOLFIRI, FOLFOXIRI, whatever you want to choose here, plus minus your VEGFR inhibitor or VEGF inhibitor, Avastin here, or you can use a EGFR inhibitor. So either panitumumab or cetuximab in patients who are left-sided and don't have a mutation in BRAF or KRAS or in one of the RASes. And so, I guess we'll stop here for a moment. I'd like to hear from the audience. What backbone do you guys typically use for stage 4 colorectal cancer when you think about chemo? Are you using FOLFOXIRI, using FOLFOX, or using FOLFIRI? Let's hear from the audience for a moment. Anyone have anything you want to say? You can just come off mute and just talk. Okay, so let's just kind of move on from there. So, I think a lot of people are using FOLFOXIRI here. I tend to use FOLFOX a lot. The data is a little equivocal. I think, there's some data suggesting FOLFOXIRI is better than using FOLFOX for FOLFIRI, although there was a little bit of equivocal data looking at FOLFOXIRI and liver mets, but let's just move on from there. So, we talked about kind of the first and second line options from a conventional perspective, typically using chemotherapy backbone, and you're either using a VEGF inhibitor or EGFR inhibitor, and then you're just switching it out. You're just switching out your chemotherapy backbone and switching out beyond that. For third line and fourth line, this is actually interchangeable, but people use Lonsurf and they use regorafenib. They can actually use regorafenib in third line or Lonsurf in fourth line. We'll come back to that. But I do want to talk about this. I think this is really important. And I will say that I am not a fan of Lonsurf or regorafenib as options for stage 4 colorectal cancer. I actually think that it was surprising they were approved at the time when they were approved back in 2012, 2015. We really needed a lot of options. And so that's why I think they were approved. But if you look at their actual benefit, right, the median PFS for Lonsurf is basically extends median PFS relative to placebo from 1.7 months to 2 months. It's a 0.3 month prolongation of median progression-free survival. Regorafenib is actually worse than that. It's 0.2 months. And if you look at the overall survival benefit, neither drug really gives you more than 2 months. And so when you think about the risk-benefit ratio of these drugs, it's really not that appealing. So I really try not to use these. I try and do trials. And so I just don't think that these are very appealing. All right, let's talk about patient number 1 now. So you can kind of see the conventional options. And the way I typically sequence this in someone who's left-sided, right? So they're a candidate for an EGFR inhibitor because they're left-sided. Right-sided patients are not. And so in a patient like this who doesn't have a RAS mutation and is left-sided, I typically use FOLFOX plus panitumumab. Then I use FOLFIRI plus bevacizumab. I'll follow that with Lonsurf and regorafenib. But I really try not to use these drugs. I'm always trying to find something else to do. But this is kind of my typical conventional therapy sequencing. From an operational perspective, this person really didn't have any operational options, diffuse disease in the peritoneum, we'll kind of move on from there. Molecular-based options. So this is something that's unique. So if you look at her profile, right, I think what you can see from her profile, she has a lot of molecular-based options. So just looking at this, these are all actionable mutations. So her ATM mutation suggests that you can use a PARP inhibitor. So there's nice data now in prostate, looking at olaparib and rucaparib in ATM deficient patients, had very nice responses. New England Journal paper, both approved for this. And so this patient has an ATM mutation. They also have an ARID1A mutation, suggesting you can use a PARP inhibitor, and a RAD50 mutation, also suggestive of HRD, suggesting you can use a PARP inhibitor. This patient has a PASH1 mutation, so that's an activating mutation of the hedgehog pathway, suggesting you can use a hedgehog inhibitor. They have this NTRK fusion, and you can definitely use an NTRK fusion inhibitor here. We're going to talk about this extensively now. And then you can use immune therapy because they're MSI-High and actually TMB-high as well. So immune therapy is a wonderful molecular-based option. So let's talk about NTRK for a moment. So NTRK is a receptor tyrosine kinase. It's just like, EGFR, FGFR, PDGFR, all of these. And so it sits at the surface, on the surface of the cell, right? Basically, activation leads to dimerization, leads to phosphorylation and activation of various pathways, so phospholipase C, gamma, RAS, PI3 kinase. So this is a nice diagram. I like when people talk about phospholipase C, gamma. Most people forget about this, but please know this is a very important pathway, and a lot of people are targeting this. So don't forget about phospholipase C, gamma. So the nice thing about NTRK, and this is every time we see someone with an NTRK fusion, we freak out, right? Like that's probably my favorite mutation to see because the response is incredible. So across various tumor types, their response rate was about 75%. But what you need to know about NTRK fusions is that the median duration of response is over 4.5 years, right? So if you respond to an NTRK fusion inhibitor, you're likely going to respond for a protracted period of time. And that's the beauty of NTRK fusions when you see them.
Right, yeah.
The problem with NTRK fusions when it comes to colorectal cancer is that only about 0.2 to 1% of patients with stage 4 colorectal cancer have this fusion. So only about 0.2 to 1% of all comers with stage 4 colorectal cancer have an NTRK fusion. But about 5 to 7% of MSI-High patients will have this fusion. So that's really nice to know. The other problem in colorectal cancer, as opposed to other tumors like thyroid, where we see a preponderance of this, is that only about 25 to 50% will respond. So although when you take all comers with NTRK fusions, there's about a 75% response rate, when it comes to colorectal cancer, that's reduced to about 25 to 50% with ladiratuzumab. So here you can see this seminal New England Journal paper article talking about kind of the overall response rate, about 75 to 80%. And here's a very nice slide I think people should know about. So we talk about the incidence of NTRK fusions in various tumors. What I think is interesting is that there's a significant number of thyroid cancer patients, roughly 6%, that have this NTRK fusion. I actually get a little jealous when I hear my thyroid cancer colleagues talk about this, because they're really experts at these drugs, ladiratuzumab and entrectinib, because they have such a significant percentage of patients with NTRK fusions. You can see there's about 1.5% cervical cancer, 1.5% glioma. So definitely test for this in your brain tumor patients. I think everyone should be doing NGS regardless, but this is actually nice to see. So these are the ongoing trials and drugs that are approved that are NTRK fusion inhibitors. So we already have ladiratuzumab and entrectinib, but you can see Simcere has this drug. Repotrectinib is also an NTRK fusion inhibitor. One thing about repotrectinib is to know, so I think this drug is going to get approved for ROS1 mutations. That's a turning point drug. That data was phenomenal. So they will almost undoubtedly get approved, but really in the ROS1 space, and then come behind it with NTRK fusions. But you can see there are several drugs in trial for that. So for patient 1, really no local regional options in this patient. And then we look at trials. So when we look at the trials in the stage 4 colorectal cancer space, there are a lot of clinical trials, obviously, in stage 4 colorectal cancer. You talk about MSI-High patients, really people are looking at ipi/nivo plus radiation, and they're looking at combination immune checkpoint inhibitors. We'll talk about this a little bit later, but LAG-3, TIM-3, IDO1. And so a lot of people are really looking at that. People are looking at trying to modify the tumor microenvironment. So using COX inhibitors, using dendritic cell vaccinations, using various drugs in that context, VEGFR inhibitors, which we'll talk about too. Lots of clinical trials in stage 4 colorectal cancer. We'll talk about this a little bit later in a different talk. I'll kind of skip through this. So when you talk about this patient, kind of think about how you want to sequence their therapy. So you kind of say, okay, they are MSI-High, so we start with immune therapy. I think most people are doing that now. Certainly I do in my practice. The big question in this patient is, do you use an NTRK inhibitor or do you use chemo in second line? So I would most likely use an NTRK inhibitor here, but the question becomes, how much disease do they have? How quick do you need a response? And so, in this context, we likely use an NTRK inhibitor. Then we come in with chemo, FOLFOX/panitumumab, FOLFIRI plus bevacizumab, your trials. And so then the question becomes, what do you do here, right? Do you use a PARP inhibitor before you use a hedgehog inhibitor, before you use regorafenib? Again, I'm really not a fan. I actually didn't put Lonsurf here. I should have. Lonsurf belongs in this kind of area too. But when all is said and done, I think Lonsurf would probably be here, but this is kind of what we think about. So this is a great example of a patient who responded to an NTRK fusion inhibitor after they failed immune therapy when they were MSI-High. So you can see this patient was MSI-High. They had failed immune therapy. They got ladiratuzumab and had a tremendous response. This kind of shows you, again, their CEA going down drastically after they got ladiratuzumab. So you can see here they progress on immune therapy and their CEA comes down very nicely with ladiratuzumab. So this patient, just to let everyone know, they're on immune therapy. We started them on Opdivo 4 years ago. They are still in a CR, tremendous response. So we move on to patient 2. So with patient 2, you can see that they also are MSI-High, but they have a different profile. So first of all, they have an NRAS mutation. So they can't get an EGFR inhibitor because of this NRAS mutation. They also have ARID1A mutations, which suggests that you could try a PARP inhibitor. The data is equivocal there. They have a beta-catenin mutation, which we'll talk about a little bit later. So this patient actually came with diffuse hepatic metastases that were unresectable. She's 55 years old. So when you look at sequencing her treatment, you look at what your options are molecularly, really it's that ARID1A mutation. You have a PARP inhibitor. You cannot give her panitumumab or cetuximab because she has an NRAS mutation, so you really can't use that. So here you can kind of see how we would sequence the therapy there. And so you've got your different trials. Again, Lonsurf should be in this particular dynamic. And so in this context, I would likely use immune therapy initially, then FOLFOX bevacizumab, FOLFIRI plus bevacizumab, and then you kind of come in with your trials. Lonsurf would be somewhere here, and then you kind of sequence any way you want. So this patient got immune therapy. She's in a CR 2 years after starting Opdivo. She did receive Y90 to the liver. So again, this patient's in a complete remission, doing phenomenally after 2 years. So we go to patient 3. Patient 3 is a little bit unique. You can see this BRCA2 mutation here, which I think is interesting. They have an APC mutation also and a PTEN loss. We'll talk about that too. So in this patient, again, the PARP inhibitor is an option because they have this BRCA2 mutation. Now, PARP inhibitors for BRCA2 more likely to work than with an AT mutation. The book is still out in colorectal cancer. This patient can get an EGFR inhibitor. They don't have a RAS mutation. So this is nice. So in addition, I should mention, they also are a candidate for, oops, something happening there. They're also a candidate for an mTOR inhibitor because of that PTEN loss that they have. So we can show that for a moment, sorry. So they have a PTEN loss, and you can see they're a candidate for the mTOR inhibitor here. So if you see PTEN, people oftentimes will try an mTOR inhibitor with varying degrees of success. So we talk about homologous recombination for a moment. So homologous recombination is one of the many ways that our body uses to repair DNA. So when there's double-strand DNA breaks, everyone knows we use homologous recombination to repair that. So you can actually see the 6 different pathways here that the body uses to repair DNA. So when cells divide, normal cells can incur these DNA mutations. So we have these different methods of repairing DNA with nucleotide excision repair, base excision mismatch repair for single-strand DNA breaks, translesion DNA synthesis, non-homologous end joining, and homologous recombination for double-strand breaks. So what we see in a lot of patients is we see a significant impairment of homologous recombination. So you can see there's a number of different proteins involved in this. And actually, this is a very nice example of this. So when you look at colorectal cancer, about 15% of patients will have deficiencies in homologous recombination. You can see the breakdown here. Most of those patients have ARID1A, or a significant number have ARID1A mutations. You can actually see that very nicely depicted here. And every single patient I think we've shown so far has had an ARID1A deficiency. So when you see homologous recombination deficiency, you can sometimes use a PARP inhibitor. And the idea is that when patients with cancers have deficient homologous recombination, when you add a PARP inhibitor, they end up having significant cell death in the cancer cell. And that's the concept. If you have a patient who's homologous recombination proficient, they actually can repair these breaks in a way, even in the absence of PARP activity. And so the nice thing is when you have a patient with a cancer that's homologous recombination deficient, you can consider using a PARP inhibitor like olaparib, talazoparib, rucaparib, veliparib, and niraparib. So there's options here. So when you look at HRD and stage 4 colorectal cancer, you can see there's a lot of clinical trials here. So Lonsurf plus talazoparib really just recently failed, but there's a lot of ongoing trials here. And so it's interesting to see that. I will say very quickly that olaparib did fail in the first-line maintenance setting when used with bevacizumab after chemo. So in this patient, you think about how you're going to sequence this. Again, Lonsurf should be here, but you kind of just do your standard sort of sequencing. And then in this patient, what's unique is because of that BRCA2 mutation, you think, well, maybe a PARP inhibitor would be more effective than a trial in this context, or absolutely think about getting a PARP inhibitor on trial, or do combination trials. So I should put that here, but definitely combination trials. So patient 3 remains in a complete remission 2.5 years after starting Keytruda. She did receive one-handed liver, so she's doing amazing too. So patient 4, this is the last patient. Again, she's left-sided, mesenteric lymphadenopathy, again, unresectable, not curable, but somebody you can do phenomenally with. And so when you look at her molecular profile, you can see that she has a BRAF V600E mutation. So what's unique there is that you can use encorafenib plus cetuximab, and the data looks pretty nice there. You can see a median PFS benefit of about 3 months. That's the approval label here. And so you can see that there, this is definitely an option. So I typically sequence FOLFOX Avastin, then do encorafenib plus cetuximab and move on from there. So here you see the BRAF V600E mutation. You also see the ARID1A mutation we talked about, allowing you to use a PARP inhibitor, and then the PTEN loss allowing for an mTOR inhibitor. So you sequence this, again, Lonsurf should be here, but again, sequencing becomes, fairly standard. Immune therapy, then chemo with the Avastin, then encorafenib, successful BRAF V600E mutation sort of regimen. You can move on from there. So the nice thing about patient 4 is she's in a CR 1.5 years after starting Keytruda, which is great. So this is kind of where I want to get. So when we talk about MSI-High patients, we talk about using immune therapy here. I think what most people don't think about is when you're using immune therapy, number one, why does it not work in 50% plus patients when it works so robustly in the other 50%? And number two, why is it that when you give this treatment, patients respond amazingly, and then some of these patients stop responding? Why does that happen? And so the idea here is that everyone's kind of focused on the tumor microenvironment, right? There's something different about the environment around the cancer that's leading to this immune therapy resistance. And in fact, many people are looking at this because when you look at immune therapy in stage 4 colorectal cancer, it hasn't really taken off. There was recent data with Avastin, with Tecentriq in the context of chemo plus Avastin that showed a 2-month benefit in progression-free survival. So I think you're going to see that. But when all is said and done, people are wondering, why isn't this cancer phenomenally responsive to immune therapy? And so there is some concern that the immune microenvironment, when it comes to stage 4 colorectal cancer, is somewhat exhausted, that there's a preponderance of T regulatory cells that reduce the response to immune therapy. In addition, when you look at this immune checkpoint, right, some people are worried that when you have the PD-1 inhibition that we basically use, say Keytruda or Opdivo or whatever for, that the cancer cell can upregulate other pathways in this immune checkpoint to basically suppress the T cell. So they can potentially upregulate CTLA-4 sort of mechanism signaling, TIM3 signaling, TIGIT signaling, LAG3 signaling. And so that there's a real concern for that the cancer cells escaping PD-L1, PD-1 inhibition by basically upregulating expression of different immune checkpoint pathways. In addition, there's a significant increase of IL-17A that's been seen in the tumor microenvironment, and people are concerned that that leads to a non-responsive tumor microenvironment. In addition, you can see an increase in VEGF. So you look at kind of what we do in colorectal cancer. We have a lot of VEGF, VEGFR inhibitors. So we've got Avastin, and we've got regorafenib, and ramucirumab, and aflibercept, all approved in this context. And so they're all designed to really block angiogenesis. And the concept there is really just to block angiogenesis, block new blood vessel formation in the context of stage 4 colorectal cancer. But what some people are also saying now, and actually many studies ongoing in this context, is that when you have an increase in VEGF, you're getting an increase in myeloid-derived suppressor cells, M2 macrophages, Tregs. So all of these inhibitory immune cells can get into the tumor microenvironment through VEGF signaling. And so if you block VEGF signaling, the idea is maybe you can suppress the immigration of these different cells into this environment and then essentially improve the response to immune therapy. Another mechanism is through upregulation of Wnt beta-catenin signaling. We'll talk about that in a moment. Actually, talk about that now. So when we talk about Wnt beta-catenin signaling pathway, you can see here that APC plays a central role. APC really involved in beta-catenin degradation. And when you have loss of APC, like we see in a lot of different colorectal cancers, what can happen is you can get an increase in beta-catenin signaling, which then leads to a reduction in immune response. And so that's something that people are looking at. The other concern with stage 4 colorectal cancer is that a lot of patients present with disease in the liver, right? The liver is the #1 site for metastases in colorectal cancer, and it is an immunotolerant organ. And there's various reasons for that, but there's some concern that the liver is somewhat unresponsive to immune therapy in various regards. And so that's part of the issue. People are really looking at the microbiome here. So some people think that the bacteria around the cancer cells is playing a very big role in response to immune therapy. Now, there's different thought process there. And in fact, this is somewhat controversial, but that's why you're seeing a lot of people target the microbiome looking at immune therapy. In fact, there are studies showing that patients who got antibiotics 2 months before and 1 month after immune therapy responded less to immune therapy because they didn't have the same bacterial environment. So I think that's interesting. Stay tuned for that. There's a lot of people looking at this. In addition, there's concern for impaired antigen presentation to the CD8 positive cytotoxic T cells. And then there's these 2 mutations here, JAK1 and JAK2. So JAK1 mutations are seen in 10% of colorectal cancer, JAK2 in 5%. And we know that those can lead to a reduction in immune response. And then we always worry about kind of the increase in the other oncogenic pathways that can lead to a reduction in immune response, MAP kinase, PI3 kinase, Wnt beta-catenin, like we talked about. So how do you overcome this resistance? So lots of people in this field trying to figure out how to overcome this resistance, because, outside of MSI-High, people would love to use immune therapy for everyone with stage 4 colorectal cancer. So that's what everyone's really looking at. How do we overcome this resistance? Not even for MSI-High patients, but how do we overcome it for patients who are not MSI-High? So there's a lot of people looking at combined immune checkpoint blockade. What if we target PD-L1 and we target TIGIT? Will we target PD-L1 and we target TIM3? Will we target PD-L1 and we target CTLA4 or LAG3? So these are ongoing trials. And so, here's one example of looking we'll come back to that. So other people are also looking at anti-angiogenic agents. So I talked about how VEGF seems to allow all of these immune suppressive cells to go into the environment so that the immune therapy doesn't work. So a lot of people are looking at combining VEGFR inhibitors like fruquintinib or regorafenib with immune therapy to see if you can increase the response to immune therapy. And really, the data has been somewhat controversial, somewhat equivocal. So here you can see this is fruquintinib plus a PD-1 inhibitor, any of these drugs, and median progression-free survival about 3.9 months. So that's okay, 3.8 months, that's not great. But what's worse to me is that the overall response rate was only 11%. But here, looking at this trial, the Reg-Nivo trial, look at regorafenib plus nivolumab, as much as I'm not a huge fan of regorafenib, the data here was actually pretty nice. They had a 40% overall response rate in the colorectal population, had a pretty good response. And this was in all comers, 25 colorectal cancer patients, MSI stable, only one of these patients was MSI high. So stay tuned for this particular regimen. We'll see what happens there. But this mechanism of using a VEGFR inhibitor plus immune therapy is being tested across all tumor lines. Like there, ramucirumab plus Keytruda is getting a lot of hype for second line stage 4 non-small cell lung cancer. So just be aware of that. It's actually pretty interesting what we're seeing there. And then of course, combined therapy addressing oncogenic upregulation. So a lot of people are looking at immune therapy plus the KRAS inhibitor, immune therapy plus the BRAF inhibitor plus the EGFR inhibitor. That's what people are doing now. So let's talk about colorectal cancer unmet needs. So third line onward is wide open. After the first 2 lines of stage 4 colorectal cancer treatment, we are just not that good. You look at the data I showed you with Lonsurf, the data I showed you with regorafenib, it's just not that appealing. It's a problem. Identifying primary mechanisms of immune therapy resistance in MSI-High patients is imperative, actually just in general, MSI stable patients as well, but this is imperative. And identifying secondary mechanisms of immune therapy resistance in MSI patients also imperative. So trials and studies we'd like to see, honestly, we kind of talk about how when patients have a lot of DNA instability, they get these new neoantigens, right? All these mutations cause these abnormal proteins that then trigger the immune system. But we don't really know what those proteins are. We don't know what they look like. If we could truly identify the neoantigens themselves, we could use that information to develop new therapeutics. Imagine you identify a neoantigen that's really causing tremendous immune therapy responses. You could absolutely use that to make new drugs and to identify new pathways to target. And so that's something I would like to see. People are definitely doing these studies, but it would be really nice to see if we can define these neoantigens. And so obviously to leverage that knowledge. And then delineating neoantigens implicated in developmental resistance. So once you know what the neoantigens are, you can see how they change to see if that change is responsible for resistance that develops with immune therapy. And so that will be, and I think that's important, and multi-omics will be key here. To do that, you really have to do proteomics, you have to do transcriptomics, you have to do RNA-omics, you have to do, standard DNA-omics, and that's going to be genomics is going to be very important. So concluding remarks, obviously, people have to test for NGS, TMB, PD-L1, MSI, and HRD. This is actually critical. And I read a paper suggesting that in 2019, only about 50% of people were testing for this. I think that's probably gone up, but I didn't see any recent data on this. But that's really concerning. Third line stage 4 colorectal cancer remains a profound unmet need. This is a very big deal. The role of immune therapy in stage 4 colon cancer remains unresolved, and MSI-High is really a bit of a black box in terms of why people respond and what have you. So we will really be doing the clinical part of this in about an hour for patients. We gave, part 1 of a 2-part stage 4 colorectal cancer series for patients. We're doing that a little bit later, and we'll talk really about treatment in a very facile way for those that are not familiar with treatments here. But that's where we are at the moment. Does anyone have any comments? I'd love to hear from anyone in the room regarding what they think the future of this looks like. Any questions, any comments? All right, so, in 2 weeks from now, my colleagues will be with us again. Ollie Ukart is here. I didn't have a chance to mention him. I appreciate Ollie being here. He's tremendous. He's a big part of our group. And so we'll be back in 2 weeks. In an hour, I'll be giving this talk on stage 4 colorectal cancer treatment. We'll go from there. Thank you, everyone, for joining. See you in 2 weeks.